Hello, I'm Professor Morie Gertz of the Mayo Clinic in Rochester, Minnesota, with expertise in the management of amyloidosis. And I'd like to address options regarding patients with amyloidosis who've previously been treated with daratumumab, vincristine, cyclophosphamide, and dexamethasone, and either failed to achieve a complete response or respond and subsequently progress. The Andromeda study has shown us that the addition of daratumumab to standard cyclophosphamide, bortezomib, dexamethasone shows dramatic improvement with a tripling in the hematologic complete response rate and a doubling in both the cardiac and renal organ response rates. For these patients that achieve a complete response, the outlook is good. However, unlike multiple myeloma, patients with amyloidosis who fail to achieve a complete response do not have a very optimistic outlook because you need complete eradication of light chain production to prevent further amyloid deposition into tissues. So the question is, what are the options? 40% of patients who receive daratumumab, cyclophosphamide, bortezomib, and dexamethasone will require additional therapy if they don't achieve a complete response, which again is 40% of the amyloid population that is treated. So what are these options? Well, a subset of these patients will be stem cell transplant eligible. They'll have sufficient cardiac reserve and sufficient glomerular filtration, their renal function will be preserved, that they can safely undergo stem cell transplant. And this is still recommended as consolidation for those patients who receive daratumumab-based chemotherapy and fail to achieve a complete response. In general, only about 20% of patients with AL amyloidosis are stem cell transplant eligible, either due to age, impairment in renal function, or insufficient cardiac reserve. What about these patients? Well, at American Society of Hematology, the French amyloidosis group presented a case series of 9 patients with amyloidosis that were translocation 4/14 positive. And these patients were treated with venetoclax, and the complete response rate was 70%. So knowing the FISH results in an AL amyloidosis patient is extremely important because these patients may be eligible for venetoclax-based chemotherapy. And this is an option for non-transplant eligible patients that don't achieve a complete response or relapse, where the 4/14 translocation is present, indicating high expression of BCL2. For patients that are 4/14 negative, I think a strong consideration for these patients, although the literature is not very strong in the area, is the introduction of pomalidomide. Pomalidomide does have activity in the management of AL amyloidosis that has failed a Dara-VCD regimen. And in these circumstances, pomalidomide produces response rate in the 50% range. An important consideration is that patients with cardiac amyloidosis do not tolerate immunomodulatory drugs well, and one must be aware that dose modifications are required because these drugs routinely exacerbate heart failure in amyloid patients and will raise the NT-proBNP significantly. So in multiple myeloma patients receiving pomalidomide, dosing is quite commonly 2 milligrams or 4 milligrams. This dose is far too toxic for the amyloidosis population with cardiac involvement. In these patients, a number of studies have demonstrated that the maximum tolerated dose of pomalidomide is 1 milligram, and this can be effective. So in summary, for patients who don't achieve a complete response, the options are stem cell transplant for those who have excellent reserve. For those that aren't transplant eligible, the use of venetoclax if they have 4/14 translocation, present in 40 to 50% of AL amyloid patients, and pomalidomide would be a next consideration. One note is that if the patient had a protracted response to therapy, let's say the patient received 6 months of Dara-VCD, had a 4 to 5 year response, and then showed evidence of hematologic relapse, it is worthwhile to consider reapplication of the administered regimen before that this is simply regrowth of the original clone off therapy, and so that repeating the identical therapy can be quite effective. Thank you for your attention.